Right, so we're going to get going. Welcome, everyone. I hope we all managed it. And just a quick thumbs up if you can hear me, because last time I didn't share my slides, so then we had a bit of a false start. So if you can see my slides, fabulous. I'm going to start sharing now from the start, and then a little thumbs up would be great. Okay. There we go. Right. So welcome to this month's Suitcase Club. We're hosting obviously by Travel Doctor. So this month we're talking about when the chicks come home to roost. So that's our theme, our little topic, and these are our chicks. So we've got yeah, you guys. So we've got Professor Lucille Blumberg and Dr. Kim Pieton. I don't think either need much of an introduction. We have and we've had you many times before with us, and we're very grateful that you come in and support us and give lovely lectures quite often. And this is going to be very cool. So we're very privileged to have both of you here. You'll see all the information there. We also, just a little bit about us and what we're doing and where we are, just for those who aren't coming in person. So we are broadcasting from the fire station in Rosebank. Yes. And that's our practice there. And we're sitting in the little boardroom. So we actually just in here now, right now. And this is a bit about Suitcase Club. If you've joined before, you've definitely heard this. So we basically are looking for cases that are related to travel, so infectious disease cases that we can submit to Geosentinel, which is a joint venture between ISTM and the CDC in the States. And they are basically looking to pick up early detection of any travel-related diseases, particularly infectious diseases that have crossed a border. So what we're looking for is people who are ill-returned travelers who have been outside the borders of South Africa, and then we can submit them as a case to Geosentinel, and it will just pick up if there's stuff coming from a specific area, any early signs we need to look for. So that is the email address or our number for our practice, and you can get in touch with us or any of us, Albie, me, Lucille, any of the doctors, any of the nursing staff. We all kind of can submit cases, so that's wonderful. I've just put in 2 slides on 2 of the things we often get questions about, and it's mainly for our colleagues who are joining, especially the GPs, whether in the area or not, that we do have the Shingrix vaccine available in the practice, and it is under section 21. So there's a page on our website where you actually have to make an application, and then we basically go through those and we administer them here and our Northcliffe clinic, and there's also a branch in Cape Town. So we do have that in stock. The other thing is malaria prophylaxis. So if you have a patient that's needing malaria prophylaxis, we are doing, so there's 4 different kinds that we are offering there. So if you have a look at the different options, we've got inbound international travelers, people within South Africa, and then the special groups of pregnant travelers and children. So we do also have an online form for that. And then a big thing is our YouTube channel. So every month I record. Oh, it's on automatic recording. I thought I hadn't started it. So we record the meeting, and then we share it on our YouTube channel. And that is so the people who can't make it to this meeting now just can have a look. You'll see we get some, like the snakes obviously got quite a bit of a traction there if you look at the views. But it's just nice to be able to go back and just see. And I know we've even had on Kim's hepatitis alphabets that we did, there was a nice comment there that someone was studying for the travel medicine course, and they were like, this is so helpful. So like it was nice. So people are looking at them, and yeah, if you guys miss it, and I usually will try and send out the link to the new meeting as an email as well after the fact. So if someone didn't arrive or couldn't make it, then that's it. And then just thank you to Sanofi who provided us with our snacks, and that's it. I'm done. So I'm going to hand over to Dr. Kim. And I'll grab yours at the end. Okay, cool. And then we're going to have Prof after that. So I'm going to get out of the hot chair.
You want me to sit?
Okay, hello everybody. Okay, so this patient is an oldie but a goodie, and I think I've presented it here already, so you might have heard it before. If you remember in March 2021, there was lots of excitement in Mozambique because ISIS was attacking different areas of the country. And specifically in northern Mozambique, ISIS was attacking the Mozambique army base. So there was lots of fighting, and our patient was working on a site which was really bordering on the Mozambican army base. And he said there was oh, okay, sorry. You all see that. He was working on a site where the border was right on the army base, and he describes fighting being 10 meters away from some areas of where they were working. So when the attacks really started getting dramatic, he and his colleagues dived for cover, and everybody kind of scattered to get out of the area. He and one of his friends hid under a structure all night. It's an Afrikaans man trying to understand what a structure means, but it basically sounded like just a roof, sort of with no walls. Maybe like I'm imagining a carport kind of thing. Afdak, yeah, exactly. So really not any protection from anybody, including the ISIS fighters, but they stayed out there all night. The next day, he managed to get hold of the satellite phone, and he arranged evacuation with Sasol, who evacuated them all to Pemba, which is in northern Mozambique and is the nearest town. And he then remained in Pemba with the rest of the colleagues from that site to wait for the area to calm down and receive further instruction. 5 days later, he developed a fever, had intense myalgia and a headache, and having worked in Mozambique for a while already, started his coartem. But 3 days later, when he was about to finish the coartem, he wasn't feeling any better, and so he decided to go and get some other help. So this is where Pemba and Palma are, right in northern Mozambique. Palma's almost on the northern border. Beautiful coastal cities, towns. And the patient was then seen in the local clinic, decided that this was more than what they could deal with, and asked that he be sent down to South Africa. And I think you guys sent him down, LB. So on arrival in Rosebank, he obviously felt horrible. He had a fever. He'd completely lost his appetite. He had quite a bad headache. He had lots of myalgia and said he didn't have any diarrhea. In fact, it was the opposite. He was very constipated. On examination, he had a temperature of 38.4. He was breathing quite fast. He was tachycardic, but a normal blood pressure and a normal sugar. And the thing that struck me when I looked at him was that he was just red all over, this diffuse erythema. And when you looked closer around his wrists and his ankles, it looked like a fine petechial rash. He did have mild conjunctivitis, so he had red eyes. He didn't have any lymphadenopathy. There were no obvious bites. He didn't have a goiter. And the rest of his clinical examination was normal. So his chest was clear, his abdomen was soft, there was no organomegaly, there was nothing else to find in the deep organs, and neurologically was absolutely normal. So his admission bloods, you can see he had a normal white cell count, but of those, the neutrophils were raised, 7.54, so just above normal. And his lymphocytes were low, 0.83, and he didn't have an eosinophilia. He was anemic. He had a low MCV. His platelets were normal. His urea was 5. His creatinine is 84. His liver enzymes were normal. His CRP was 201. Our malaria was negative. His albumin was low. His rickettsia IgG was positive. PCR was negative. Hep studies were negative, and this, remember, 2021 was almost the Delta wave, so we were testing COVID left, right, and center, and everything was COVID, was both negative. The next day, his neutrophils more or less the same, lymphocytes starting to come up a little bit, platelets were still normal. kidney function test still normal, CRP still dramatic. And so you see his blood sort of staying pretty similar during the couple of days that he was with us. So you probably can't appreciate the diffuse erythematous rash, but I think you can see over his knees that he was definitely reddish. And I asked him, is this sunburn? And he said, absolutely not. He's always got a huge hat. He's always got a neck and long sleeves and suntan lotion if he doesn't have that. And he didn't feel it was any sunburn. And some of the areas of the rash were more macular papillarish. So this is his hand. I don't know. I think he was lying on that, yeah, crouching. Could be. So you can good ones. You can see the oh, somebody's talking. You can see this sort of macular papular, maybe some petechial type areas over his hands, and then in a V distribution, which is why I initially thought, is this real or is this just sunburn? He was quite erythematous. And then after he'd been in hospital for 2 days, the colleague who was also under the structure all night sent him this picture and said, this is what I look like. So yeah, so that guy was feeling okay, but had a really dramatic quite rash. And I tried to get the friend to come to us to have his blood taken and for me to examine him, but he didn't want to come. Probably, yeah. Oh, it was. Do you remember, Albie? I seem to remember these guys being in Klerksdorp, Stilfontein, somewhere in the northwest. So, what are we thinking about? When they sent him down to me, the clinic had made notes about, is this typhoid? Does he need ceftriaxone and being treated as a salmonella infection? But I think you'll agree that the rash doesn't really look like a typhoid rash. He had ceftriaxone in the clinic and hadn't improved. He'd had all the coartem and hadn't improved. And they'd done a wheel Felix test in the clinic, which they love doing in north of us. And it was positive. One component was positive. So I don't know what that even means. But so they sent him as a typhoid, but he may have. I mean, it wasn't a terrible thought. It was definitely part of the differential, but he should have made some improvements on that. And so we started thinking a little bit further and diagnosed him as chikungunya virus infection. So the fact that he'd been outside all night, had many mosquito bites, was red all over, had conjunctivitis, and by then, later in hospital, developed really terrible arthritis in both of his knees, made us think this is most likely an arbovirus infection. By the time he got to South Africa, his PCR was negative because it was over a week. The NICD did the PCR and serology for us. The chikungunya PCR was negative. The IgM serology was positive. The IgG was negative. The dengue IgM was also positive, but the titers were lower than the chikungunya. With the joint pain, with the fact that he was sick, but not critically, he wasn't severely sick. His liver function was normal. His hemodynamically stable. He seemed to have a milder illness. So we thought these are probably cross-reacting antibodies, and the dengue is less likely, and it's most likely chikungunya. So a couple of slides on chikungunya. The virus is part of the Togaviridae family, and it's an alpha virus. And the vector for spread is the Aedes mosquito, the pretty one, which is day biting and has these pretty stripy legs. There's lots in my garden, stripy legs. The incubation period is usually between 3 and 7 days, but can be as long as 12 days. chikungunya comes from the Kimakonde or Makonde language, which means to become contorted and to walk bent. And this implies the severe, or tries to describe the severe joint pain that many of these patients have, back pain and peripheral joints. Some of them with severe arthritis, debilitating, can become chronic and so sore. And so this is how they landed up with the very cool word chikungunya. The life cycle of the chikungunya virus is usually in non-human primates, rodents, and birds, where an Aedes mosquito will bite a viremic animal. The virus will replicate in the midgut, can replicate in the ovary, neural tissue, gets inside the body cavity, and then will make its way into the salivary gland, so that when the virus bites a human during a blood meal, the virus enters the human through the salivary glands, human or non-human primate, or whatever, a mammal type thing to pass this virus on. And similarly, then you need to have a viremic mammal for the mosquito to bite during the blood meal to become infected. The distribution of chikungunya is quite far across the globe, and I think Lucille's going to tell us a little bit more about the epidemiology and some of the outbreaks. But these are mainly in the southern hemisphere, but you can see it is in the northern hemisphere, sort of tropical and subtropical regions. But the current areas of interest are South America, Southeast Asia, and now we've got big outbreaks happening in Reunion Island, one of many. And I think the epidemiology of chikungunya is so interesting because they've been able to map these outbreaks so carefully and see how it's spread across the globe. So in the 1960s to 1980s, there wasn't really much happening until 2004, when a large epidemic started. You can see where the blue arrow is, on the coast of Kenya, and from there it spread across into the Indian Ocean islands, so down into Madagascar and Mauritius, other islands in the Indian Ocean in 2005. From there, it also spread across into West Africa, and we saw outbreaks over there. But then from 2005, you get the Indian Ocean outbreaks spreading up into Southeast Asia. And from Southeast Asia in the late 2000s and 2010, going up even into these Mediterranean countries in Europe. And then again, a bit of a lull until it popped up in the Caribbean. And then in 2013, from the Caribbean, spread down into South America. So it's been there for ages. It hasn't been well described until the 1960s, but the Caribbean has always been a hotspot for chikungunya, and most likely been as a result of the slave trade from West Africa going across into the Caribbean. So what's happening now, just a quick slide on that, is this year, the chikungunya has really been quite dramatic, and of interest to us is Reunion, which is an island on the southwest coast of Africa, where they've had massive amounts. Oh, sorry, southeast coast. Sorry. Southeast coast. Yeah, exactly. I'm thinking Saint Helena and saying Reunion. Southeast coast. I think in this European CDC article, they said over 40,000 cases on Reunion, which is a tiny place, and 4 deaths, but that's up until March. So now we still had April and a bit of May as well. And I just wanted to show you the change from the previous year. So always South America, a little bit in West Africa. Last year, Southeast Asia hotspots. And this year, Southeast Asia is not really featuring at all, but rather these other Indian Ocean islands. So how does chikungunya present? The clinical signs can be multi-system, but usually pretty superficial involvement. So joint pain occurs in the vast majority of patients, but not all patients get arthritis. So it's more of an arthralgia. Almost all of them have a fever. Most of them have a headache. Half of them will have muscle pain. Less than half of them will have a rash. Joint swelling only in a third, and digestive symptoms, so diarrhea or nausea in a third. It's often difficult to distinguish between chikungunya and dengue. They've got similar vectors, the transmission is similar, the clinical features are similar. So a couple of things to try and say which one is more likely to be chikungunya, which one is likely to be dengue. So both of them have fever, but the joint involvement is far more common in chikungunya. The arthritis is far more common in chikungunya. And the rash, maybe, in this article, they say the chikungunya is maybe a little bit more of a rash than what dengue has, versus dengue being more of a muscle pain, myalgia, rather than arthritis or arthralgia, and dengue being far more likely to bleed, although dengue seldom bleed, but these are arboviruses and potentially viral hemorrhagic fevers. So that's much more likely in dengue. The blood count is far more dramatic in patients with dengue. Low lymphocyte counts, low neutrophil counts, low platelet counts. And if you remember, my guy did have a lymphopenia, but his neutrophils were good. His platelets were normal. So just if one is trying to work out, conjunctivitis is more common with chikungunya than with dengue. Chikungunya is a far more milder illness, very rarely severe or fatal. And of those who get the joint manifestations, the arthralgia, 30% of the arthralgia will be arthritis, and 30% of the arthritis will develop chronic arthritis. So these patients suffer for months and years afterwards with severe joint pain. And I think that's the debilitating part, why you don't want to get chikungunya, because of the terrible joint pain. How do we make a diagnosis? So like most infections, we rely on trying to identify the organism itself, either with a PCR, in this case being a virus, which needs to happen as soon as possible because the viremic phase, like with most viruses, is really short. So if you catch the patient in the first 5 to 7 days, you can send a PCR. Once the first week is done, the PCR is seldom positive. And so one then relies on serology. IgM should become positive around about 3-4 days and can persist and stay positive for 3 months. The IgG will become positive around a week, and one expects the IgG to remain positive for years afterwards. The NICD does the PCR and the serology testing for us. Okay. How do we treat these patients? Like most viral infections, there's no antiviral. So one really has to support them and try and look after the organ systems which are affected. So they need fluids, they need analgesia, they need antipyretics. And then in those patients who have the severe joint pain, the management of this. This man developed quite severe arthritis with effusions in his knees. And I got the rheumatologist to aspirate the fluid out of the knees. And sometimes they need to go once a week to have this. And the relief from that was huge. So that becomes then a really important part of their management because it's so debilitating. I tried to have a look at chikungunya in South Africa because most of this chikungunya are imported cases, and it's possible to set up local transmission events, but there's really not much data or information about that and outbreaks in South Africa. So in 1977, this article was describing an epidemic of chikungunya between Aedes and a group of baboons, who 92 baboons in this area had serological evidence of chikungunya. And they then collected mosquitoes around the same area. And the Aedes furcifer was the kind of Aedes in that area. And most of these Aedes mosquitoes that they caught and looked at were infected with chikungunya at the time. And then there was a group of people living close to this area, and there was a local transmission then set up, and these humans had got it. And so the article is basically just describing how in this, the baboons were the main reservoir, with the Aedes transferring it between the humans that were living close by. So that was quite interesting. And this was in northern KwaZulu-Natal. But since this, 1977, there isn't another description. Maybe John and Lucille know another one.
Yeah. Micah. Yeah, so Micah was the area, very close to you.
I stole this slide from my dengue slide because I think the same thing applies. Chikungunya in South Africa, so we've got Aedes aegypti, we don't have Aedes albopictus. The Aedes mosquitoes in KZN, Limpopo, and Mpumalanga, and in Gauteng. And so we do have suitable environments in KZN, Limpopo, and Mpumalanga, probably not Gauteng, it's too cold. We've got the right climate in some of these areas, we've got the vector, and we've got a very vulnerable population because none of us have been exposed, and so we have the potential for an outbreak. We don't have any vector competence on chikungunya in the Aedes mosquitoes in South Africa. So what can we do? We need long-term vector surveillance programs. So this was again taken from my dengue slide, and this was from the dengue vector surveillance program, which they've got in KZN, looking for the potential for dengue outbreak. We need to have a rapid recognition response to arbovirus outbreaks in our country. We need to be able to test local populations as well as migrants and returning travelers to catch these. And we need research programs to try and assess the prevalence and risk mitigate. And so this center in KZN hopefully is looking at chikungunya as well as dengue, but the article is all about dengue, so they didn't really mention chikungunya. What is useful in South Africa is that we don't have competent mosquito vectors at the major air entry airports into South Africa, being Joburg, OR Tambo, and Cape Town. But although that's in our favor, I think from areas in Africa where are issues with chikungunya, those people are probably not going to get into the country necessarily by air, and we know ground migration is significant, so people and goods are coming by road all the time. If they come in through a port, KZN certainly got competent vectors, the right tropical environment to support a local transmission cycle. And so we could easily potentially introduce viremic people and set up infected mosquitoes in these arbovirus permissive areas. The second problem is that chikungunya, compared to dengue, is far more likely to be asymptomatic or cause a mild viremic illness. And so many of these people are not going to seek medical care because they feel better after a couple of days, or they never felt sick to start off with. And so introduction of these arboviruses could go unnoticed until we've already established a big endemic cycle. The testing is difficult because you can't just send this off to any lab. It's expensive. It requires limited access. It requires transport to the NICD. The blood needs to be taken under proper conditions and packaged and transported in a safe way. So if you're not in one of the major cities, you're probably not going to be able to get this testing done easily. And so early recognition and diagnosis are key, but as you know, very challenging. So what happened to this patient? After the third day, he was transferred out of ICU and his steroids were stopped. He had, as I said, really severe bilateral knee and ankle arthritis with mills and mills and mills of fluid aspirated from his joints. And in fact, the fever wasn't worrying him. The rash didn't bother him in the slightest. His main complaint was the terrible joint pain. So you're thinking back to his blood results and why has he got this microcytic anemia? We did iron studies on him. He was found to be iron deficient and he had a colonoscopy and he had hemorrhoids which were bleeding intermittently. So the HB of 10 and MCV of 70 was a red herring and had nothing to do with chikungunya. And after 10 days, he was discharged and feeling much, much better. And as I said, we thought that it was much more likely that he had chikungunya and not dengue.
Why was he on steroids?
The joint pain. Yeah. Yeah.
What's the moral of the story?
Yeah, exactly. So just for the record, it wasn't during that admission, the colonoscopy, like how to stretch out your private care as much as possible. Yeah. Yeah. It's an immune mediated, yeah. Yeah. So he got intra-articular steroids, which helped enormously. But he was in ICU in the beginning, and our critical care specialist is a big believer in steroids for everyone. I know, yeah. So, yeah.
I don't have any questions on the chat yet, but I'll just, if any come in, we can do it.
Are the animals symptomatic? Do they have arthritis? I don't know. It's a good question. They may just be reservoirs. Edie's versipa breeds in the trees, so it's all tree holes, so it's all tied up with the ecology. Okay. All right. So thanks very much, Kim. That was great. I think you've covered most things. So yesterday, the WHO had a session on chikungunya related to the outbreaks. So I have used their slides. I'm not going to repeat what Kim has done. So I'll just pick out a few things from the slides and then speak about the current outbreaks. So I think you've covered this. Just in terms of alpha viruses, if you want to know other alpha viruses, they are Synbis is an alpha virus, and Nyong in West Africa, in East Africa, and Semliki forest, but not dengue and not Zika. So there shouldn't be cross-reaction with the serology, which is what you get with the flaviviruses, yellow fever, dengue, and Zika. But still, you know, serology is just serology. So the severity, I think you've mentioned it, but it's more severe in newborns, young infants, and the elderly. And you'll see what's happened in Reunion. The overall case fatality is really low, but it's the morbidity that is a problem. And chronic disease is not uncommon, and it's not uncommon to have joint pains up to 3 months, and some much longer. And we had a technologist or scientist at NICD who did a little stab of her. She was working with chikungunya virus, and she had chronic arthritis, many, many, many years, and she was quite debilitated. I think you've done that. So the big problem with chikungunya is that these mosquitoes also transmit lots of other viruses, as you know, and they breed very well. They breed in any kind of source of water, and particularly in overcrowded cities, urban areas, where there's not good infrastructure, there are many opportunities for these mosquitoes to breed. And they transmit all the other diseases, yellow fever, dengue, etc. So, you know, these are quite difficult to control. Importantly, and I think you mentioned it, you need surveillance. And in Mauritius, they were really good at picking up the first cases. I think the rest, I think you've discussed. Okay, so here's chikungunya in Reunion Island. As you mentioned, they had the big outbreak in 2005, 2006. They had an estimated 250,000 cases. Not everybody gets tested. And, you know, it's kind of estimated, and they use clinic visits to try and estimate those numbers. Since 2010, 2024, there's been no local transmission and only just a couple of imported cases. But at the end of winter, end of August, which was winter, they noted, I think they've got some surveillance for fever, acute febrile illness. They had notification of positive PCR check. And their diagnosis in Reunion is PCR. It's not serology. They found that it was no link to imported cases and there was local transmission. There was limited circulation for 2 months and then it started to expand. So you can see from the green area down to the red area. And this is where it is, the dark areas as of May the 7th. And if you look at the epidemiological curves, they think the outbreak is starting to go down. But we'll have to wait and see. So they don't, they do visits to family medicine clinics, but they don't confirm them. But I think, you know, there's a correlation between the two. And you can see they confirmed quite a lot. And it really spreads very easily, very quickly within a place where these mosquitoes breed very well. So interestingly, they've had 300 hospitalizations. It's not of notifiable disease, but I think they have some sort of data collection. And as we mentioned at the beginning, it's pediatric cases, and it's mainly for pain management, pregnant women for fever and maternal fetal transmission monitoring. And then they had 65 cases where there were comorbidities, mostly in older patients. And they've had a couple of deaths. So I think the outbreak there is going down, but Mauritius had a later start and it's ongoing there. Some of them were imported, some of them were local cases, and some of them, they weren't sure. But I don't know if that black area is where most of the holiday people go. I've only been to Mauritius once and it was Club Med. Yeah. So, yeah. And I don't know, Grand Bar is where Club Med is. But I went there 30 years ago, so I can't remember. Okay, so these are their cases. Not a lot. I think most are recovered, still some are getting better. But I think they have a good hold on the outbreak, and they have very good control measures. And I'll show you a case that occurred there. And 5 minutes after the picture was taken, the people arrived to come and spray the household and fog locally and clean up all the water, you know, those things. So this is what they do, intensive vector control. It's very different to the mosquitoes for malaria. So they do fog and they are sort of active during the day, but similar to malaria, they do clean up. You're not allowed to have, like with dengue, you're not allowed to have pots of water at your household. You'll get, if you're in Singapore, you'll get fined. I don't know about other places. Protection for pregnant women, young people. If you're sleeping, you must sleep with a bed net during the day and use insect repellents. There are 2 new vaccines. They have been registered in the States. They're available in the UK. I'm not sure where else they're available. They're single dose, and they're quite different. Nobody's sure of the efficacy, but there's a recent study showing some people still got it, but maybe a milder attack. But I think the data is still coming out there. But it's obviously one of the tools. And I think in Reunion, they're going to start vaccinating. So if you were infected before, you may have some protection, but it's not complete. So I think the immunology is still kind of being investigated. So this is a friend of mine went with a swimming group to do some open water races in Mauritius, and a local South African family that they got to know last time was visited by the group, and there's a 16-year-old son, and he had a fever, bit of myalgia, not a lot of joint pain, and that's his rash. So they did test for chikungunya. I don't know what they did, if it was serology or PCR, but he was told they were positive, but he was still told he can write exams, and he should. And they were about to arrive to spray, the area, because Mauritius has very good public health, very good surveillance, and very good responses. So ongoing in Mauritius, have we had any imported cases here? Well, I don't know where they get tested. So certainly NICD's got testing. I think one of the private labs also tests. And as you say, not everybody goes. So we've only had 2 positives for the year, and they were both serology, IgM. One was from Kenya and one was from Mauritius over the last couple of months. So I think the advice to travelers is use some insect repellent during the day, and come and see us if you have illness when you come back. And that's it. Has anyone biopsied it? And that's from a dermatologist, steroids in one hand and a punch biopsy needle in the other. I don't know. I don't know what the histopathology is. So could you do PCR on tissue? I don't know. I mean, it's a viremia. I think some of the manifestations are immunological. Is there a vasculitis? I'm not sure. Yeah. Okay.
I've got one online. I'm just going to come there so we can.
Okay.
Yeah. So, what is the possibility of getting chikungunya and dengue at the same time from a common vector? Has this been described in the past? So sort of about
yeah. So they're similar. I mean, the vectors are the same. The area is the same. I sort of lost one slide. It shows you where the dengue is and the chikungunya, and some of them are exactly the same. So can they both? I guess it is possible. Yeah.
We thought we had a case, but then it was a fault. I think the chikungunya.
Was it virus?
Yes.
Yeah. I don't know.
They were bitten by 2 mosquitoes.
Yeah.
So I don't know. I think there are lots of questions. So it's during the day. So it's daytime biting. So I think your patients were bitten late afternoon when everything happened, or during the day. Yeah.
Cross reactivity, yes.
Yeah. So they shouldn't cross react. But serology is serology, and it's it's supportive. If you get seroconversion, that's good. But I think it's not a definitive diagnosis.
It's very interesting what you say about serology. We just had an organ donor came back positive for hepatitis A, and obviously they wanted to use,
which I think is better than the arboviruses.
Yes, yeah. But the patient's liver enzymes were completely normal, and so they wanted to use her organs, and unfortunately, very few people offer a PCR. But we've managed to find a lab in KZN, and the PCR came back negative. So they're thinking it's cross-reactive.
Yeah.
False positive IgM.
Yeah.
Okay.
The IgG was negative, yeah.
So did they use the organs then?
I don't actually know. It took quite long to get the PCR, so I don't know. But it just goes to show you the serology, there's often
serology is difficult.
the IgM.
Yeah, you've got to be very careful. Yeah. We get Brucella IgMs every day, and people who are a bit tired, and you think, what do they mean?
Diagnosed on a single IgM positive,
which remains positive for very long.
But these patients were never
exposed.
They weren't even exposed, but their IgM was positive.
Yeah.
I'm going to close the online meeting off, but we're going to carry on chatting. Thank you to everyone who joined online, and I will be posting a link for the YouTube page as well, the latest upload once I've edited it, and I'll send that through to everyone. So yeah, subscribe to our channel and like. Okay.